Welcome back everyone to part 2 of this pharmacokinetics topic. And in this part, we're going to be talking all about the different phases of pharmacokinetics. Now, as you can see, there are a lot of objectives for this part of the topic, but in this first recording, we're just going to concentrate on these ones here in terms of drug administration. And we'll look a bit at first pass metabolism and then distribution. So pharmacokinetics, we're talking about the relationship between the administration of a drug, the time course of its distribution, and the magnitude of the concentration attained in different regions of the body. And as I mentioned here, we're talking about drug administration, absorption, and distribution. Now, this is just a summary slide that should be very familiar to all of you looking at what a definition of pharmacokinetics, what the body does to the drug in terms of processing it from absorption, distribution and storage, metabolism and permanent excretion. And we've already talked about pharmacodynamics. And again, please refer to this diagram when you're studying in terms of the phases of pharmacokinetics and that overlap then with pharmacodynamics. And so yes, this is what we are going to talk about here: administration, absorption and distribution. The most common mode of administration is oral. Oral administration of tablets or liquids. Then we have intravenous injections of a dose of a drug, so into a vein, and also infusions via drip. Straight into a muscle, so intramuscular, and then under the skin being subcutaneous. Some drugs are inhaled for respiratory conditions such as asthma. Also, some drugs can be put under the tongue, so sublingual tabs, because there's a good venous supply under the tongue. Application to epithelial surfaces, so topical administration. Rectal administration as well. And then other specialized routes as well, so intra-articular administration into joints, or intrathecal into the spine. So what I'm going to do now, using a video that I made previously, is to take you through 3 different modes of administration of the same dose of a drug in the same person, and looking at how the mode of administration will affect the peak plasma concentration that dose of the drug will reach, and also looking at how the mode of administration affects the time that it takes to get to that peak concentration. So my apologies in advance for this pretty dodgy graph that you're about to see. But here on the y-axis, we have the concentration of drug in blood. And here on the x-axis, we have time in hours. If we just go up here, I've just drawn this little map from the gut to the liver, to the inferior vena cava, the right side of the heart, the lungs, the left side of the heart, and the aorta, and then the systemic arterial system further out from that. Now, what I want you to think about is any drug. I'm going to use prednisone. You can have anything in your head, but it's the same drug at the same dose for all 3 modes of administration in the same person, which is Marge Simpson for the purpose of this exercise. But this is important. Same drug, same dose, same person. We're going to start with our first mode of administration being oral administration. So you swallow a drug, goes to the stomach, goes to the intestines, gets absorbed, goes via the hepatic portal system to the liver, from the liver then into eventually into the inferior vena cava, into the right side of the heart, through the pulmonary circuit to the lungs, back to the left side of the heart, out of the left side of the heart via the aorta into the systemic arterial system. Now that's even taken me a long time to say it. So when we look at the curve produced for this sort of administration for prednisone, in my case, you can see that it's taking quite a bit of time to get to its peak concentration, which is quite low. And then it's also taking time for that drug to be cleared from the body. So the Cmax, which is the maximal concentration in the plasma, is quite low. And the Tmax, which describes the time it takes to get to the Cmax, is quite long. Okay. All right, now let's have a look at our second mode of administration, which is IV, so straight into a vein. You can see by going into a vein, we're skipping the gut and we're skipping the liver. So from the vein, it just goes to the right side of the heart, through the pulmonary circuit, back to the left side of the heart and out through the aorta. So when we look at the curve for this sort of administration, you can see straight away that the Cmax is higher and the Tmax is shorter. Okay, so it's reaching a higher maximal concentration in the plasma and it's taking a much shorter time to get there. And then you can see that there's sort of this steeper descending part of this curve as it's getting cleared from the body. All right, our last mode of administration here is inhalation via the lungs. You're skipping all of these steps straight into the lungs, back into the left side of the heart, and then out into the aorta. And this type of administration would produce sort of a curve like this, where the Cmax is even higher than the IV mode, and the Tmax again is shorter. If I had drawn these curves properly, and if you were to calculate the area under each of those red, purple and green curves, you would see that it's the same for all curves, right? And the half-life of that drug is the same for all of the modes of administration, because the area under the curve will be the same for all of the modes of administration. Now, this is why I did highlight at the beginning, because the half-life and the area under the curve is the same, because this is the same drug at the same dose in the same person. Now remember, well, we haven't done it yet, but the half-life describes the time it takes for a concentration of a particular drug to be halved in the plasma. If, however, I had given this drug at that dose to, say, Bart Simpson or Homer Simpson, then these curves might have looked a little bit different, because you have to think of the people's genetics in terms of genetics coding for proteins. And we know hepatic enzymes are proteins that are involved in the elimination, so metabolism of a drug. And they're also involved, say, in those coding for those proteins in the renal system that act as transporters. So yes, it would vary from person to person, but those curves are showing you that the area under the curve will be the same, because it's same drug, same dose, same person. So you might be looking at these three curves and thinking, well, why aren't all drugs, inhaled or put straight into a vein? But what this is showing you is, say, and this is just an example, right? This is showing you that this red curve for this drug might be a very safe mode of administration, because it's not getting to too high a concentration, but it would still be having a therapeutic effect at that concentration. Whereas if you were to give that drug IV at that dose or inhale it at that dose, these concentrations might be toxic to the person or produce too many side effects. So all of these sort of considerations are considered when modes of administration and doses of drugs are prescribed. Now, the last thing I'm going to say about this curve is about first order enzyme kinetics and zero order enzyme kinetics. In the next recording, I'll give you an example of how alcohol follows zero order kinetics, but the clearance of most drugs from the body follows first order enzyme kinetics, where the rate of clearance of the drug is determined by the actual concentration of the drug. So the higher the concentration of the drug, the greater the rate of clearance. I've just put a little definition here of first order kinetics being the concentration of drug determining the rate of clearance. So in terms of drug deposition and the overall phases of pharmacokinetics, this slide here is really nice to sort of describe what's going on. I want you to take note of the central role there in green of the plasma. And so, as we mentioned previously, we have all these different modes of administration here. And then we have absorption and distribution. And you can see all of this movement of drug molecules in and out of the plasma and into lots of other different compartments. And then, of course, we have elimination of drug molecules through the processes of, metabolism and then excretion. And most drug molecules being excreted in urine, but some via feces through the digestive tract, some in milk, particularly, in basic drugs in lactating mothers, so you need to be careful of that. Some in sweat, and you can see down here one of these sort of modes of administration is inhalation of drugs directly into the lungs. Some of that dose that goes into the lungs then enters the plasma, but some of it then is just exhaled and expired air. So I leave that with you, and you can have a look at that in your own time. So drug absorption is the passage of drug molecules from the site of administration into the plasma, and it does depend on the route of administration. And we've talked about these routes of administration before: oral, under the tongue, rectal, as in suppositories, application to epithelial surfaces, and those surfaces being the skin, the cornea in the eye, vagina, and nasal mucosa, also via inhalation and also via injection. And that might be intramuscularly or intravenous, or under the skin, or intrathecal, which is into the spinal canal. Now, absorption is influenced by the rate of dissolution, so how fast the drug dissolves. And I'm sure you've seen on some of those packets of Nurofen, there are different names, kind of Nurofen Avance, because it acts quickly, it's absorbed quickly. And that's kind of, got to do with, say, the sugar coating the tablet sort of allows for that dissolution to occur more rapidly. It's also influenced by the surface area of the membrane. So say, for example, we know the small intestine, and we know that through the digestive process, nutrients are absorbed across the villi and the microvilli of the walls of the small intestine. And the same thing then happens with drug molecules. Now, as I've mentioned a couple of times before, most of the drugs that we tend to take are administered orally in either, tablet or liquid form, about 80% of them. So if you do have sort of somebody with liver disease, or say somebody with a stomach ulcer, then this oral administration might need to be changed to a different mode of administration. We're going to talk about this phenomenon, first pass metabolism, here now. Now, just like, nutrients being the end products of digestion are absorbed across the gastrointestinal tract wall into the portal system and delivered to the liver, so too are drug molecules that are taken in tablet form, so oral form, and also rectal form. Now, with first pass metabolism, it does involve the gastrointestinal and hepatic metabolism. So it does involve enzymes in the gastrointestinal tract wall. And after a drug is absorbed from the digestive tract, it is delivered to the liver, as I mentioned, via the portal circulation. So orally administered drugs metabolized in the liver will therefore undergo first pass hepatic metabolism. What does this mean? Let's say you take a prodrug, so it's in an inactive form. Those drug molecules go to the liver, and via the first pass metabolism process, that inactive drug is converted to active drug. However, for other drugs that are taken in oral form, the first pass kind of greatly reduces the amount of drug that enters the systemic circulation. Let's have a look at this down here, and it doesn't matter what the drug is, but here we've got a dose of 100 milligrams of a particular drug, and in the small intestine. Okay, so it's absorbed across the GIT wall into this portal vein. You can see, though, from this initial dose here, that 20 milligrams is not absorbed at all, and it's going to, just pass through the digestive tract and be excreted. So once in the portal vein, then this 80 milligrams that's left is undergoing first pass metabolism here, and you can see that it is extensive first pass metabolism because we're losing another 60 milligrams of that 80 milligrams. So what actually enters the systemic circulation in this case is 20 milligrams of drug, and that is 1/5 of the initial dose. The mode of administration then will determine the amount of drug that actually reaches the systemic circulation. Let's say, for example, this drug here, and as I have no idea, but just let's say it's aspirin. This 1/5 of this dose, so this 20 milligrams, might be a very safe dose of this drug to enter the blood, and it might have a great therapeutic effect. If you were to administer this dose, say IV, then you would have a different situation, right? Because administering IV, it goes straight into a vein. So therefore it bypasses the liver and therefore bypasses that first pass effect. And so that 100, milligrams entering the bloodstream might be very toxic and an overdose. Now, some drugs do undergo really extensive first pass. An example is morphine. And it is nearly all inactivated in the liver. And it's for this reason that you wouldn't normally give morphine via oral administration. So leading on from first pass metabolism is this term here, bioavailability. Bioavailability describes the amount of drug that actually reaches the systemic circulation as a percentage of the administered dose. As I mentioned, IV administration, all of it, so 100% of a particular dose will reach the systemic circulation. But for oral and other routes, it does vary. And, that relates to that first pass metabolism in particular, which occurs mostly in the liver due to the action of hepatic enzymes, where in this case, only 1/5 of a dose of a drug is actually reaching the systemic circulation, and the remaining then is inactivated and removed. We're going to finish up on this part of the topic by looking at the different body fluid compartments and how drug molecules can move in and out of these compartments. A bit of revision to begin with. As you know, the total body water as a percentage of body weight varies from 50 to 70%, being less in females than males due to the higher adipose content in females. We have three main body fluid compartments. We have the extracellular fluid, which includes blood plasma, interstitial fluid, which is that fluid surrounding tissue cells, and we also have lymph, a small amount of fluid there, and lymph is that fluid that flows through lymphatic vessels in the lymphatic system. Intracellular fluid then is all of the fluid that's found inside all of our body cells, and it's a lot. It's about 30 to 40%. Then we also have transcellular fluid, which is only, accounts for a small proportion of total body fluid, and it's that proportion of total body fluid that's contained within epithelial line spaces. So it includes these fluids, cerebrospinal fluid. We have small amount of fluid, in the eye, so intraocular fluid, including, aqueous humor and vitreous humor. We also have that, serous fluid produced by serous membranes, so peritoneal fluid, also pleural fluid. We've also got pericardial fluid. We've also got synovial fluid and digestive secretions as well. Now, cellular barriers exist between the intracellular fluid and the transcellular fluid. We also know from our study that we have drug molecules that exist in free or active form, and we've also got them existing in bound form. So, bound to plasma albumin, for example, and in that way they're inactive. And we also know about the dissociation of weak acids and weak base drugs into charged and uncharged forms, depending upon, the pH of the compartment that they find themselves in. So this is a really nice diagram over here on the right, sort of summarizing everything that I've been talking about. We've got all of our different compartments there that you can have a look at. You can see we've got bound drugs and unbound drugs that exist in each compartment, but you can very clearly see here that it is only the unbound form that's capable of moving from one compartment to another. And so in terms then of distribution, it is influenced by three factors. We have firstly blood flow, then the ability to leave the blood, and finally the ability to enter the target organ. Blood flow will determine how much drug actually reaches a target site. You want to have, a good blood flow to a particular target site. But in some sort of pathophysiological conditions, let's say somebody has hypertension, and if that hypertension is being caused by the heart beating too fast, then, that flow is going to be too great, and, you're actually going to get a decrease in the drug reaching the target. And similarly, if you have stasis of blood flow, flow not occurring normally, that is also going to impact on the amount of drug that's going to be able to interact with targets. We also have the ability to leave the blood. As I mentioned on the previous slide, only the free or unbound drug can leave the blood. And the blood CSF barrier is only permeable to lipid-soluble drugs. And that's because of sort of those tight junctions that exist between those epithelial cells lining the blood-brain barrier, which will only sort of allow then the passage of lipid-soluble drugs. And then thirdly, distribution sort of is influenced by the ability then of the drug molecules to enter the target organ. And kind of then bringing everything together and talking about equilibrium distribution, this pattern of distribution between the various compartments then depends upon kind of all of the things we've been talking about, right? So the permeability across tissue barriers, binding within compartments, so, binding to albumin in plasma, also that pH partition, which will mean that, sort of weakly acidic drugs will accumulate in a compartment if the pH of that solution in that compartment is basic, and vice versa. And then we also have that fat to water sort of partition, which is important for a few drugs. And if that fat to water partition is high, such as in the case of, thiopental, where it's 10:1, then you do get the drug molecules accumulating in that tissue. And to enter the transcellular fluid compartment from the extracellular compartment, the drug must cross some sort of a cellular barrier like blood-brain barriers.